attend to patients with diabetes, ask necessary questions, do the necessary investigation, start treatment, and will be able to identify complication on time and send the patient for expert management. And you know where to send the patient. Number 5, Cardiocare. That's how. You have the address too. You must put the address. So, that being said, okay. So, that's still fixing this slide. So I was saying, so, you know, hypertension, heart failure, they've saying all these things, ECG, EKG, APC, you know, all those things. But diabetes is just simple, metabolic disorder. And the good thing about diabetes patients is when you manage them well and sugar is controlled, I promise you they will live up to 100 years without complication. And they keep on being your patient. You won't have decapitated, all these things, intractable, hypertension, all those things. With anti-diabetic and insulin, everything, and patient is good. You're happy, patient is happy. But the most important thing is actually taking care of the complications and knowing when it comes and when to tackle the complications. So, I don't even know where it comes from. So, yeah. People have been complaining about this. Okay, thank you very much. We can start. We're presenting diabetes, practical steps for primary care. That's the word, primary care, whereby you will be able to do this thing. My name is Dr. Aghanya. I'm a consultant physician endocrinologist. By endocrinologist, what it means that this diabetes, now we they run them in Nigerian parents. So by the end of today, I'm sure say it go fit run them too. So this outline is going to be the way we're going to follow it. What is it? Why should we care? How we recognize and evaluate patients, appropriate care, and referral when due. Let's start with the case. Let's test our idea of diabetes. A 42-year-old newly employed office executive, while undergoing routine office medical checkup, found to have a fasting plasma glucose of 9.0 millimoles per liter, 9.0 millimoles per liter, and a blood pressure of 110/80. No other presenting symptoms. It's just okay, a routine investigation. Otherwise, he said it's very stable. Now, is this patient diabetic? Don't be in a hurry. Like I said, this is primary care. Now, yes, no?
Those that say no, say aye. Those that say it depends.
Nobody said no, Zef. It depends.
Those that say I don't know, say aye.
I don't know them.
A few of them.
Okay. Let's know if yes, no, I don't know, or it depends. Now, how will you make a diagnosis of diabetes in this patient? Repeat fasting blood sugar, OGTT, HbA1c, all of the above, none of the above. Is it? You are making diagnosis. Okay. Let's go.
We will learn now.
Don't worry, let's go. So, the first question is, what is diabetes? That's the first question. And the way we define diabetes is a metabolic or endocrine disorder that affects both carbohydrate, fat, and protein, characterized by hyperglycemia. which is as a result of relative or absolute insulin deficiency associated with complications. This is the definition of diabetes. But now, this is Torenchi, long English. Now, for your patient that comes in, you can't be speaking this English for the patient now. The patient needs to understand what you're talking about. If not, the broker, the pastor will take your patient from you. Now, to that patient, diabetes is the inability of the body to absorb glucose. Why does it happen? Because the key that opens the door for the glucose to enter where it's supposed to enter, which is insulin, is either not functioning well or is missing. At that point, you will look at him. You continue. Now, if this glucose doesn't enter the body, what normally happens? The glucose now starts floating through the body, and while floating there, it starts causing problem. It can affect the eye to cause even blindness. It can affect the heart, the kidney, even the feet, burning feet. The calf muscle can affect it. Now, for male patients, please, you must always tell them it's going to affect their erection. At that point, patient looks at you and says, my brother or my sister, can you repeat the last part of that statement? And I promise you, you have the person's attention. So always have it in mind.
I want to recognize Dr. Emmanuel Ndontre, Director of Education from the Nursing and Midwifery Council. You are very welcome, sir. Thank you.
Thank you. Welcome, sir. So, why do we care? I use 4 million deaths each year, but Prof used per minute per day. That cause problem. So, you reduce lifespan 5 to 10 years, and as you can see from yesterday, heart attack, stroke, everything increases with diabetes. But let me tell you, the word is uncontrolled diabetes. That is not that sentence. So, if it's controlled, all these things goes away. I assure you, in Barry's voice. It can cause kidney disease, as you can see. Also, the IDF estimated $850 billion as of 2017. This is 2025. I know as the economy be, by now, might be $1 trillion. So it's a multi-systemic illness, you know all these things. So how do you classify diabetes? Because you need to classify it to know what you're managing. But this is the normal, newest WHO classification. I don't know when you finished school. We had the old classification, and this is the newest one. So you have type 1 diabetes, you all know, that occurs in younger individuals, autoimmune, and always as a result of total insulin deficiency. Then the type 2, which we are going to emphasize more, the commonest in the environment, occurs in older people, which can be as a result of insulin resistance and relative insulin deficiency. It's a continuum. It starts being resistant. At the point, towards the end, it becomes deficient.
Please, hope you are writing. Hope you are writing. Not fail today. Today is the final day. No remedial test.
In short, I'm going to say this question myself. So, they have the type 3, which is hybrid, which is classified into the ladder and the ketosis prone. Ladder is what we call the slowly evolving type of diabetes. It used to be called type 1.5. Occurs in patients less than 35 years. They resemble type 1, but they don't have DKA. The ketosis prone is also called, what's the name again? I remember. These people that are type 2, but they don't have ketones in their body. So in case you see a patient you're suspecting type 2 without ketones, think of insulin prone. Then other specific types, you know this one, so hormonal causes, pancreatic issues. Now we have the 5th one, which is called the unclassified. Flatbush diabetes, that's ketosis prone. The unclassified. Now unclassified is when you have ruled out all the possible causes of diabetes and you can't find any cause. You are free to say this diabetes is unclassified. So in the environment, if you are confused, write unclassified and leave it to us to classify it. Now, hyperglycemia affected in pregnancy, we have diabetes in pregnancy and gestational diabetes. That usually occurs at 24 to 28 weeks of this patient. It was discussed yesterday. Now, the risk factors, talked about it yesterday, Prof talked about it. Family history of diabetes plays a major role in type 2 DM. If it's unfortunate, father, mother, diabetic, they can have diabetes. Prof said it yesterday. So it's very inheritable. And in some cases whereby father is not diabetic, mother is not diabetic, son is diabetic. Now when you go back, the grandfather or the grandmother might be diabetic. Unfortunately, the father didn't pick it, the mother didn't pick it. They now say, it is not in our family. You know, that's kind of things we hear. Not in our family. Where did I get diabetes from? My brother, let us manage it. Forget about where it came from. Obesity, yes. Obesity is very, very cardinal. But we are so concerned about central abdominal obesity, like this flat. When I mean central abdominal obesity, that's a major concern. Someone can be so fat and the glucose is normal, but that abdominal obesity causes insulin resistance. It downregulates receptors. That's what the problem is. So if you're exercising, try and be doing sit-ups. If you don't want to exercise, don't do sit-up so that you reduce the abdominal fat. So, habitual physical inactivity. Now, this one is what we call soft life. You know, the bushes, you know, that do things. Now, the houses are smart houses. Siri, give me water. Siri, open the curtain. AC on, light, you can't even put off switch. Light on, bam, bam, you know. AC, you know, break one single sweat. Now enter your Porsche. They will go down, enter your elevator. Some people don't climb staircases in their offices. I know them. They like the lift. Now enter the office, AC, come down in the evening, go to the pub where the guys they drink alcohol, eat your ECU, everything, enter your AC, go home, sleep. So I think the message is clear. No need emphasizing that. Race, ethnicity, Africans are always implicated in everything. Pima Indians, previous impaired fasting glucose, GDM, hypertension, these are the risk factors. Now, in the second case, remember our first case, so we never finished that one. Second case, 38-year-old woman presenting the ER, history of weight loss, polydipsia, polyuria, generalized body weakness, with blurring vision and painful sensation on the feet. The presentation of diabetes in both parents, of which the father died of diabetes complication. Average basal penetration is 26.9 millimoles per liter. Blood pressure 160/100. What type of diabetes is she more likely to have? Type 2. Type 1, hybrid, unclassified. That one there, none of the above. So,
some people are voting.
they don't vote finish. Oh.
No, it's only one person that's voted. 2 people have voted.
Okay.
2 people have voted. I realized yesterday a lot of people don't know how to use QR code. Though. Ah,
You have taught it first before.
no, that one is another webinar. It's 18 people, 21 people. Okay.
Please, can I get name of those that voted type 1? I want the name.
This is how PVC is supposed to work, Abi.
Unclassified, I have no problem. You are confused. Unclassified. But type 1, please, let me get their names out.
Hybrid. Stuff. People are moving stuff. We have 100 votes, 105 votes. All right, let's move on.
Okay, let's move on. So now how do you make this diagnosis? Now, this will now answer all our questions of diabetes. Now, when a patient is working on his own, or you are doing routine office investigation, someone comes in, you do a fasting blood sugar, and see more than 7 millimoles per liter. Okay, any problem? No. Are you drinking water? No. Are you losing weight? You wake up in the night to go and piss? You do anything like that? Any infection anywhere? No. You are sure? Okay. RBS 11.1. Are you sure you don't have family? No family. Nobody in my family. No. Even my grandfather, I met him. He died of natural causes. At this point, there's no symptom to match a 7.1. Because, when you say a patient is diabetic, that person is diabetic for life. What you do at this point, get this person, Oga, or Madam, go home, eat your food, not to go and stop eating sugar, live your life, come back again. Let's repeat this fasting blood sugar or RBS. Now, if he comes back and they see 7 millimoles per liter, brothers and sisters, that person is diabetic. Now, if this patient came with, I'm losing weight, drinking water every time, urinating, all sorts of infection coming up and all those things, and fasting is 7.1, greater than 7, sorry, that patient is diabetic, not to prove otherwise. So now, in our first patient, an executive living a posh life, no complaint, fasting of 9. Is that person diabetic? At that first measurement, let's look for you.
It doesn't have symptoms. If you don't have symptoms and you have greater than 7, on one occasion, is that diabetic? So you need a second time, Abi? Good. If he has symptoms and greater than 7, then diabetic confirm, Abi? So that one had just a routine screening, and then you found it. So by technical definition, he's not yet diabetic, Abi? Technically. So you can repeat it. You don't have to wait for 2 weeks, so like 3 days, 5 days, short time, repeat it and start. Now, there is a catch, which you can see others. If you do your HbA1c and you start seeing some other things that are telling you that this sugar has been high for a long time,
Pointers.
or you start seeing signs of diabetic-related organ damage, you now may not need to wait for that second time. But based on that case that we have looked at, you need to do it again if there was no other thing.
Yes, what's the question, sir? Yeah. Okay, that's a catch to it, but
his question was that if he tells the person to go and come back, and the person does not come back again, so what do? You can't solve Nigeria's problem. You can only solve the problem in front of you.
Because for instance, if that fasting blood sugar is what you call isolated fasting, because you can have blood glucose going up isolatedly on its own. Now, you now say you're diabetic, start taking drug, diabetic. Next thing, they carry the patient unconscious and come to your clinic. Does it make sense?
No. So you better to do it properly.
Properly, you understand?
This is why diabetes is a multidisciplinary measurement care team. You should ideally pass on that person to your either community nurse, your community health extension worker, your social worker to follow them up. So even if they don't do, they can call them. These days we have GSM. They can call them. Can you go to a nearby place and do it and get it? So simply calls. So you need to pass on to the next level of people that can go in and follow them up properly.
No, I want to ask. So this thing I explained until Chief shouted, people now started answering. Am I supposed to be shouting? Really? I don't voice, so I get serious voice. I just want us to understand this and make sense. So you go fear on them. So that's why I'm being calm and taking it. Stop me, ask any question if you want to. So now you understand the diagnosis of diabetes now. To avoid any issue of labeling someone. Some people have been on metformin 2 weeks after they now come and see me, they are not diabetic. Someone saw something. You want to upgrade 6.6. So there are some things you need to understand making those diagnoses. So now, who do we even screen for diabetes? According to their record, all adults overweight with complications of hypertension, dyslipidemia, family history, check those people. Gestational diabetes, macrosomia, check those people. Adults greater than 45 years of age, irrespective of risk factor, check them. But I'm telling you, any patient that enters their clinic, check do RBS.
Please.
Do RBS.
Please screen everybody.
Screen everybody. There's no
These guidelines are for paper, and they are because in situations where the government is paying for the entire population, so they now decide to choose.
Find a way to cut their cost.
So please, a woman with loss of hair, loss of pimples, very likely. Infertility issues, abnormal menses, very possible. Those with gestational diabetes or having a big baby, very possible. All people. But generally, what we do, our practice, is that everybody should, once they get to your clinic, for something else, use that opportunity, check their blood pressure, check their sugar. Nobody should pass through your clinic for malaria and you did not check their blood pressure. That is a sin. Please and please.
Then, there's this thing about malaria and typhoid. Malaria and typhoid. Is an epidemic in everywhere in Nigeria, Abuja, Gombe, everywhere. Please, in that malaria and the titer is always very, very high. MP2 pluses, patient is walking and smiling, MP3 pluses, that kind of thing. Please do RBS. Some people had DKA, giving them malaria and typhoid, this thing, please. So, that 38-year-old woman presented in ER, history of weight loss. It's an interactive session. So we juggle your brain, let's know what you've learned, and you ask questions, we clarify. That 38-year-old woman presented in ER, history of weight loss, polydipsia, polyuria, generalized body weakness with blurring of vision. We talked about this thing before. So now, this patient, what other investigations do you think will be good for this patient? Full blood count, abdominal CT with focus on the pancreas, pancreatic enzyme assay, and all of the above and all the above.
Many others, but none of the above. Yes, let's vote. Our INEC is very transparent. No need to go to High Court.
All of the above. This, okay.
The 38-year-old woman, can you switch to the slides? Can you switch back to the slides?
Please.
Go back to the slide. Go.
Diabetic.
Use your previous.
Okay.
Use your previous.
38-year-old woman presenting ER, history of weight loss, polyuria, polydipsia, generalized body weakness, blurring of vision, painful sensation on the foot, family history of diabetes in both mother with father of diabetic complication, RBS 26.9, and blood pressure 160/100. Which other investigations are very important in managing this patient?
Oh yeah,
full blood count.
So let's go back
abdominal
to that.
CT.
So let's manage abdominal CT, full blood count, pancreatic enzyme assay, all of the above. Many others, but none of the above. Vote, 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 vote. You can do it. We believe in you.
Please, if I say...
Those of you that are not voting, what's the problem? You don't have PVC? Or you are free? Don't worry, nobody we can tell. We can't tell who voted.
So
you can fail honorably.
For the older people there.
And it's better to fail. Because what you fail, you will never fail again. Better to fail now. So please, just do it. It's anonymous. Truly it's anonymous. We will never know. Truly.
For the older people here, they have to use what's called option A4 in Nigeria then, in the voting system, whereby your candidate will stand, you come out. If you like collect rice, collect beans, you must stand in front of the candidate. This thing will make option A4. This, all of the above people should start.
Okay, so 173 people have voted, right? Okay, and all of them say, so you want to be doing pancreatic enzyme assay for that person? An abdominal CT, and full blood count? No, we're not looking for those kind of things. Back to the slides.
Okay.
We're not looking for all those kind of things, I think.
Please, it's a primary care approach, please. So now, how do we evaluate diabetic patients? How do they even present? A patient can present asymptomatically. No symptom, nothing. He's talking on the pulpit or he's walking on the road, the person will collapse. Cry, the person come. This patient is diabetic. Or he's walking on his own, nothing. You know, bros, we are doing free screening. Okay. We are doing free screening. You now see RBS of 15.22. We've done it now when we are doing outreach. 20 something, people are still coming in. Now, we have the classical symptoms of polyuria, polydipsia, the one you know, drinking water, pissing every time, weight loss. Type 1 DM patients are basically slim people. Type 2 are the bourgeois. They are very obese looking, as the overweight, with abdominal obesity. Now, they can come with acute complication of DKA, HHS, hypoglycemia, if they are on medication. Then chronic complications they can come with can be macrovascular form of kidney issues, retinopathies, neuropathies, stroke, MI, skin changes. These are the different complications they can come with, and they can come in combination of all this one person. Now, taking a history of this patient, first of all, take a history of what they present with, the weight loss, everything. That's what you are coming with. After that, always ask history of family history in this patient, because it gives you a pointer what you are dealing with. You can have a type 1 DM patient at 30 years or 40 years. We call this low onset type 1. So that's the essence of all this history. But in management, you can realize that such patients, all these are OHAs don't work for them. They want insulin directly. Now, if it's a woman, issue of pregnancy issues, macrosomic babies in the past, then was she ever told that she was diabetic in any of the pregnancies in the past? And after delivery, the diabetes went away, and she never checked herself, and now she's coming down with diabetes. Now, comorbidities, hypertension, dyslipidemia, in the abdominal result in the past, lifestyle, smoking, alcohol, this is how all these things lead to diabetes. Diet and nutrition, like I said, the diabetes is supposed to be more of people eating so much. But in the poor country, diabetes is coming up because they are they're adopting the urbanization. That's the problem. In the olden days, in the villages, you go to farm in the morning, come back in the night sweating. But now everybody is living posh life everywhere and eating what they're not supposed to eat, canned food and ice cream and stuff. So, you don't tell me time before. So that's by it. So, examination, we check the neck, head, skin. These will give you signs of possible complication the person is presenting with and signs of insulin resistance. Now, like I said before, I check all those stuff. Now, these are the basic investigation. You must always, when I mean, that patient should not leave that. So don't even give her medication. The patient must do this. You know, you're not controlling only blood glucose. As a specialist, you are managing other possible complications that the patient might come in with, which is dyslipidemia. Diabetic patients have dysglycemia and dyslipidemia, and this thing can cause acute events, cardiovascular events in this patient. You must do the PEEP profile. HbA1c must be done to monitor this patient's glucose. EUC must be done to check their baseline EUC at time of presentation. If there's need for us to intervene at that point, you start intervening. If not, tell the patient you repeat this thing 3 monthly to check what the outcome is. Urinalysis will be checked. ECG will also be checked. Some patients that have long-standing diabetes, that have chronic complications of neuropathy, they can have a silent MI. Without chest pain, the patient can collapse and die. Microalbuminuria for the renal impairment, uric acid is also checked in this patient. So there's no pancreatic enzyme here. This is the basic investigation. So now if a patient comes with something else, probably sepsis, you can do a full blood count, chemotherapy, you can check all this. But for a diabetic patient, this is the baseline you must do in your assessing this patient, wherever you are. Whether in the village, township, wherever it is, please always do the investigation. Now, it's an abomination to review a patient, diabetic patient, treat only the sugar, like I said before, without checking blood pressure, foot and their pulses, and looking for complication, and most importantly, educating these patients. How do you treat this diabetes? Alleviate symptoms, improve quality of life, cardiovascular risk factor and blood glucose optimization, prevent delay and minimize complication, reduce morbidity and mortality in these patients. These are our targets. For lipid, I've been saying this since yesterday now, so it's a common thing. Education and empowerment, very, very cardinal and key, because if you also understand this is a grammar of metabolic, glucose, what do you call it, insulin, they will not understand what we're talking about. Please, you have to simplify it, educate them, make them understand. Lifestyle modification and dieting, pharmacology treatment, then preventing cardiovascular risk. Now, the most important bedrock of diabetes management in Nigeria is what? Education. If you don't educate this person, you will not take that drug. If you don't educate this person, someone will tell her, come, please, there's one place, if you go there now, diabetes will go. And you collect money, and nothing will happen. A patient paid $1,000 for diabetic belt in Guadempa. It's not funny. Not telling me that they can't even see the man again, and the man has gone. Seriously, diabetic belt. You know, if I think they give her mixture to drink it, belt. As you tie belt and diabetes will go. That is the essence of being educated. Educate these people. And the worst, this internet thing now, God. Someone woke up and said, I have treatment for diabetes. It's what you see, 100,000 likes in 2 seconds. I'm telling you. In short, I think I'll just say, I have diabetes treatment. Let me see if anybody will talk. Please, education matters so much. Make them understand what is going through. It's not the end of life. People live with this thing. If you tell your passenger is diabetic, I see causing problem in Nigeria. So education is the most important thing here. Very, very, very cardinal. Now, self-monitoring of blood glucose. Let me tell you, any patient that you're managing must have a glucometer. It's not expensive now. They must get, not might, because this patient, you know, when we are in school, there's no glucometer now. So if you are feeling anyhow, sure, if you carry a patient inside the hospital now, suspected diabetic, what do? If you know now, you collect glucose and push. If the patient is hypoglycemic, he will wake up. If it's hyperglycemic, nothing happens. That's it. But now, people have glucometers everywhere. I have my own now, everywhere. To make it simple. So why would you want to go and start bringing glucose and push? No. Patient is feeling anyhow in the house. Test yourself. If it's low, take something. If it's high, look for the doctor immediately. So they must, not a matter of chance, go and get money and buy that glucometer. Now, many signs of complication, and that you need to understand, please, for this hypoglycemia, there's this thing about a patient presenting for the first time, heart rate is always 15, 16, 15, 16. You now start treatment on this patient. The truth is that this patient will come back and tell that this drug is not working. Why? Because the glucose has gone down. Now, you do RBS, you see 5, 6, which is normal. But these patients are having signs and symptoms of hypoglycemia. As a doctor, what's happening? I was okay before, but now the sugar is controlled and feeling it's a very simple thing. We call it relative hypoglycemia. What happens is this: the brain is so used to high blood glucose every time coming in. So what does it do? It upregulates transporters so that it can balance that 15, 16, 17 having every time. So when the glucose now goes down to normal, the body is used to. The brain doesn't have meter. Only thing you know is that sugar is not coming enough. You need to activate sympathetic and autosympathetic system. So now that you're hungry, give me food. But the beauty of it, assure the patient that this thing goes away. The brain on its own will readjust again and start feeling well. You understand it? It's a common thing that happens when you start managing patients. So, like I said, by the time you explain to the patient, you're going to say, now you're the runner. So, this is the lifestyle. We talked about this one, changing dietary.
You must take time to go back to that slide.
Okay.
You must take time and emphasize this to your patients.
Please.
You will not get very good control without doing this. Exercise 30 minutes a day, 3 to 5 times a week. Okay, but they will not start with 30 minutes. They will start with 10 to 15 minutes and increase by 5 minutes every 2 weeks. Then, most of the time, we're looking for aerobic exercise. Okay, then weight loss program. Then the dietary measures. You don't want to say keto. You don't want to start doing all those funny diets. So we want to have a mix of reducing complex carbohydrates, proteins, and fats. We also reduce salt. And then movement. This lifestyle idea is not something you do once and go. It's a way of living that they must continually do. They always take the stairs. They always, how many people were struggling to park close to this hall? If they drove in, they will park the farthest because it's a continuous mindset that they are continually doing. So that's what you want to teach them. Alcohol reduction, the type of friends they keep will determine whether they will keep a good control or not. If they still have guys that go out every night, they will not get a good control. And they will not tell you. So this is the whole concept of adjusting lifestyle and diet together. Okay.
Yeah. Thank you, sir. Thank you very much. You know, we have been talking about lifestyle since yesterday, so I was thinking that they know their lifestyle now. So control is all encompassing symptoms, glucose control, patient motivation. Patient needs to be motivated that, look, I tell you that if you start this medication, everything is going to be okay. I'm sure what you are giving, in case it doesn't happen, so that patients manage comorbidities. So now, this one now is an algorithm, how to follow this patient. Like you said, first thing is educate this patient on what is involved and what the possible outcomes. Then medical nutritional therapy, MNT, is the next thing. Dieting, what they are going to, we talked about, all the same thing. And for monotherapy for this patient, basically we start with metformin. Metformin is good, improves insulin resistance and also reduces hepatic glucose output. So with that,
let me explain this thing. Let me explain that off a slide.
Okay.
So I want you to see something, guys. Hello? Are you still awake? We are doing it together. Okay, you saw my name on the beginning, so now there I could come in small. By the time you see a patient, where's my pointer? Okay, good. By the time you see a patient, we are now trying to manage the patient. We will divide the patient into 3. Those with no symptoms, after we have made the diagnosis, those with mild symptoms and no acute illness, those with severe symptoms or acute illness. If they come with no symptoms and no acute illness, like that executive we had in case 1, and this is their blood sugar, average fasting is 140, HbA1c less than 7%, we will now check, is this person motivated enough to do everything? If they are well motivated, you can consider lifestyle treatment only and reassess in 3 months. If the targets are met, great, continue that. If the targets are not met, then we go up to therapy. Do we understand that? If, however, we check them and we say that morale low, or their average sugar is already high and their HbA1c is already high, you must start treatment immediately. So either their values are this, HbA1c is less than 7 or less than 7.5, but above 7.5, you need to start therapy immediately, whether their morale is high or not. But if it's here, we now check that morale and decide how that goes. We now check in 3 months. If target is met, we can continue like that. Otherwise, if target is not met, then we come to dual therapy. Are we all following so far? Yes. Beautiful. So, if there's a picture you want to snap, this is the one you want to snap. We used to have it in our jot. I don't know that it's there this year. This is the one you want to snap. If you join the WhatsApp group, we'll try and share the slide on the WhatsApp group. Now you now come here. If they have mild symptoms and this is their sugar, or the targets were not met before from these other ones, then we go straight to dual therapy. Metformin and sulfonylurea or DPP-4 or SGLT, English. Metformin or plus glimepiride or plus vidagliptin or plus dapagliflozin. We now check targets not met in 3 months. By this time, we should be calling a specialist and or adding insulin. Same thing if there's severe symptoms, acute illness. That case he presented last, that we said you do abdominal CT. So high, all the symptoms, father died of diabetes, please. That is severe. HbA1c was very high. Sugar was 230, I remember. Yes. That one, insulin should be considered, and specialist should be considered immediately. That is not for primary care. And then we start doing all of that. Do we understand it again? Do you understand it? Should I go back again? Simple. No symptoms, mild symptoms, or severe symptoms. If they have severe symptoms, involve a specialist early and start dual therapy plus or minus insulin. If they have mild symptoms, no real illness, some dysuria, some polyuria here and there, and HbA1c is high, start to dual therapy straight. You can do vidagliptin, metformin together, metformin glimepiride together, and go on straight. And then every 3 months you check for whether you have reached your targets. If, however, they have no symptoms, just routine, we decide how high the sugar is and HbA1c or the average fasting blood sugar. If it's not too high, we can consider just, if they are motivated, we can consider lifestyle. Lifestyle is for everybody, but these people can leave them only on lifestyle. However, if it's quite high, start with this, or they're not very motivated, monotherapy, and then if it's not in 3 months, we go to this thing. Please know when it impacts your power. By the time you are getting to 3 drugs, by the time you need to add insulin, by the time you're not getting control in 3 to 6 months, by the time you have severe symptoms, please start considering this. This is adapted from AACE. Okay, so we just put it together for Nigeria. Is that clear now? Awesome. Is that clear now? Perfect. So let's use one of the cases again. Is there any case that we can remember? There's one in front. Is this one here? Should we use this one? Yeah, 49-year-old CEO, type 2 diabetes, daytime sleepiness, wife says always snoring. He is treated on metformin 3 times a day, glycoside 160 milligrams twice a day. BMI is 36.2, HbA1c is 10. Yes?
That's why I had small.
He had small. He had small. What do we think? Number 1, metformin is not to be that high. You don't normally go more than 2 grams a day. So by that time, somebody is supposed to have done something. So it's on metformin and it's sulfonylurea. So let's go back to that our chart again. Let's go back to that chart.
Let me see. Okay, chart. Okay.
That's our chart. Please just keep that in mind. Good. So in this case, is he asymptomatic or symptomatic? Symptomatic, mild symptoms. HbA1c was what? 10. So, and then he's already on 2 drugs, not so? So he's already somewhere here and targets are not met. So at this point, you should be considering either adding another drug here or specialty or insulin or other agents. So he's already somewhere, HbA1c greater than 9%. You should be adding insulin, or you can add another agent, and we'll go to the next slide to explain what agents you add. Is that clear now? So when you see this patient, this is exactly how you are approaching them.
So this patient, please, specialist, this patient, because it's our patient. Look at the one. Chief, the one you're talking about is this one. 60-year-old, non-diabetic for the past 30 years. glucophage 1 gram BD, dianyl 5 milligram BD, having difficulty with achieving control. He was placed on dapagliflozin 10 milligram, which showed some improvement, but was not sustained. How will we adjust the patient's drug to achieve good glycemic control? So this patient is on glucophage already, we talked about. Now, unfortunately, it's on dianyl. Please, you don't use dianyl again. Dianyl is a very bad sulfonylurea because it causes pancreatic exhaustion on time.
Hello?
So
Shotipo, did you hear those sleeping?
Please, if a patient is on dianyl, please remove it from that place and trash it. Don't go home with it. Trash it immediately. Dianyl is not a good drug at all. You have other ones. Glimepiride is very, very okay. It works for patients. Now, the problems here now, you can see, is on dianyl, which is already out of it. And this patient is already on 3 from what you talked about before. He's on dapagliflozin, he's on sulfonylurea, and he's on metformin. So at this point, what do? You said send to specialist or insulin, not me, or insulin, or send to specialist. But the problem is that it cannot convince them to start insulin in Nigeria. Impossible. So the same thing is happening here. Always start with metformin, unless there are contraindications. You should understand that there are some patients that have serious reaction to metformin. Spurious diarrhea is so bad they can't even go out. And they are telling you, I say, no, take it to work. No, please, you have to remove. End-stage renal disease, you don't use metformin for these patients. Now, you now use alternatives. After there, you go to glimepiride, like I talked about. Do not use dianyl for anything. I repeat, do not use dianyl for anything, please. After which, and don't go beyond 2 milligram of, some people give 6 milligram of Amaril.
What are you looking for?
For 5 milligram of pioglitazone. You know, you wondering, now this is not 1980, this is 2025. We have a whole lot of drugs to play around with. A lot of insulin, not that time you use syringe. It comes in pen forms. Like this. Pen forms. You can even put it like now. Do you know if I'm using insulin? It's in my pocket. You don't even know. So these are things you know. After that, if it's not working, you move to the next step. You add your DPP4, or if it's on glimepiride, DPP4 add glimepiride. After which, you now add your fluoxetines. This is a diabetic drug that was stolen by the cardiologists. Does work good for us, but you know, we are brothers and sisters, we always allow them. This is the change drug that changed the treatment of diabetes, because it has no business with the insulin and pancreas, whether it's gone or it's there. It follows a different pathway and it changes things. But now, if you don't have control, at that point, you know what to do. Send the patient to our shop. Number 5, yes. So immediately, don't waste time. So we've done that one. Then that question Chief was talking about, there was a catch I put there. That's why say the snoring. Now look at the question. What is likely the cause of this sleepiness in this patient? Does not have failures.
What? Obstructive sleep apnea.
Yes.
So he's not sleeping well at night.
Obstructive sleep apnea. Good. Now, do you think there's a link between diabetes and obstructive sleep apnea?
Is there a link between snoring excessively and diabetes and obesity? Perfect. Okay. And heart failure and stroke and hypertension and polycontrolled hypertension. There is a serious link between that.
There's a barrage of bad links, not a better link. Bad links with obesity. But now, diabetes, obstructive sleep apnea patients, okay, have diabetes, 40% of them have diabetes and everything. So now, is there any medication? Now, which insulin will use in this patient? The truth is, insulin makes patients to gain weight. So in these patients, we don't use insulin for them. If they can afford, it goes to your incretins, GLP-1 agonists, straight up, they are Ozempic and Monjaro. People know these ones. They don't want to talk about it. We know these ones now. So now,
please, so this one is, we are just saying it so that we know that you will know that we have stuff. Not be saying that you go start them. At that level, you should get specialist inputs. This one is just to show that please, by the time you have done 2-3 drugs, you are still not getting control, you are having all these issues, multifactorial. Please, at that point in time, you need specialist inputs. Please.
Okay, this patient
let's move.
Heart failure patient, not controlled. So, what will you use? Sulfonylurea? Yes or no?
Sulfonylurea is like glymepride.
Glymepride. Will you use in heart failure patient? You know, when I put this in, that people will see this patient, you know, different forms of diabetic patient, heart failure, stroke, everything. So to know the drugs that can help you, that's why I put all these different case scenarios. So now the answer is no for pioglitazone because it's food absorption. Don't give me time before. So complications, you can have acute, chronic complications. I talked about it before earlier. Retinopathy, stroke. Now, city-owned businessman, for the past 15 years, not comparing medication, presented to the clinic with change in color of the big toe. RBS is 13. There's calf pain while walking, blurring of vision, body sensation on the feet. On examination, dark region of the foot, right big toe. AUC was normal. Analysis, 2% of protein, and the range fasting lipid profile. This is a barrage of issues. So in this patient, what complications do you think the patient has? Let's go back. There is calf pain while walking. What's it telling you?
Peripheral artery disease.
Blurring of vision.
Retinopathy.
Body sensation on the feet.
Neuropathy.
Yeah, that's all for them.
Because of that.
So
2% of protein. Nephropathy.
Then the range lipid profile, that's this lipidemia in this patient, please. So an intervention for this food is please send to, don't do anything, just send patient immediately to the right address. Now this patient, this is another case people should also be wary and careful of. And non-diabetic for the past 20 years, who has been regular with medication, he has taken medications. When he notices it's only because when he notices excess urination and tingling on the feet. In recent time, he has about 3 episodes of hypoglycemia in the past 2 weeks, which made the patient stop his drug. The glucose has since then been under control without medication, and the patient attributed the improvement to church revival he attended 2 months ago, where the pastor touched his head and said, "You are healed." What do you think is happening here? What do you think? Miracle?
Miracle?
I'm a Christian, but you separate miracle and facts.
What God cannot do?
Well, this one, I know talk. Please, this one is nephropathy. The kidney is going down. Please. And it's not clearing insulin. So you have so much of it in the system helping him to work.
So nephropathy we are looking at.
Yeah.
Nephropathy. So can we take any questions? Time is up, Abi.
Please.
I cut out the other slides.
Chief, why you talk that? Please, before we go, there are common questions patients ask you in clinic. Really?
You passed it. You passed it.
Bros, put this slide again. No verse. This one is
questions.
important.
Any burning questions?
Give me slide again. It's important.
Questions? Question?
Yes, Prof. Please, can you...
That Prof, put on for command.
Please clarify again the concept of pre-diabetes.
That's because you talk about it. That's why.
Yes, I want you to clarify for that. And also classify the role of metformin in pre-diabetes.
Okay.
Okay, so
this thing.
You passed it. Quite a while. Continue answering.
Please, this is a very important slide. Common questions patients ask in diabetic clinic and their common beliefs. The first one ask you, doctor, is this disease curable? You know what to answer?
Yes.
What do you say? Huh?
There's nothing God cannot do.
We can be managed. Please, anybody that tells is going to cure this disease or this metabolic condition, that person is a thief and a liar.
Yeah.
Please, know that one. 2, how do I reverse this diabetes? That's a common question they ask. How do I reverse this diabetes? My brother and sister, there's no reversal. We only manage this diabetes. And with good management, patient lives a normal life. And there's no problem. Am I going to be on this drug for life? Yes, so you must be on it. Not before.
Yes, so everybody
you will be on it.
ACS 2025.
You will be on this
drug for
life.
Drug for
life.
Some people are not saying it, they are not sure, or they don't believe it. God forbid. There is no God forbid in the matter.
I'm telling you, Nigeria,
please,
not my portion, and God forbid is our problem. But
I believe people can be healed miraculously. Oh, yes, but we are in ACS. In ACS, drug for. Don't let them come down with a stroke, MI, and you are not there. You will pay part of that crime.
Now, will this drug affect kidney and liver? No. The disease itself can affect the kidney and the liver, and if you don't control it, the drugs will help you out of it. Don't you understand? Because they say I'm taking 4 tablets, so won't affect my liver. It's worse if you don't take that drug at all. Please encourage them. Then for insulin, that's where the problem is. You say, no, that means my diabetes is the worst diabetes in the whole world. It's not. Even the drug you're taking is, what do you call it? Is making the insulin come out. So why don't you just leave the pancreas alone and now take the insulin? Reserve the pancreas. It's simple. If you be pylori,
we have run out of time, we need to move.
Sorry. So always encourage them, and let me tell them just use it for 2 weeks. They'll come back. They will not stop using it.
Somebody asked
the question of pre-diabetes. Now, you see, in the problem of pre-diabetes, you need to make the patient understand. Because when you tell a patient pre-diabetes, what you hear is, thank God, though. There's no thank God in this one. No thank God in this one. Pre-diabetes has 2 problems: insulin resistance and beta cell dysfunction. Unfortunately, if it's only insulin resistance, the pancreas will be enough to meet up the demand. Because what it means is that if you need 100 units of insulin to carry out work, you need 200. But the pancreas will be enough to give it out. But in pre-diabetes, over time, this function goes down with lifestyle, lipotoxicity, glucotoxicity, and in the end, it overwhelms the resistance. A patient becomes diabetic. So it is not a way out. When you say, praise the Lord, I thank God. No. This is coming. It's on the way. So lifestyle modification is very, very important to reduce stress on the pancreas, because the pancreas function must go down. I hope you understand. I answer the question. So that pre-diabetes is lifestyle.
The second question was that, is there a role for metformin in pre-diabetes?
Now, studies have been done. Commercial studies have been done. People that even have family history of diabetes, tell them on metformin, still had diabetes in the end. I want to start before I go to pre-diabetes. Studies that were done show that people that had family history of diabetes, father, mother, the children were still on metformin to avoid diabetes, and they became diabetic in the end. So in pre-diabetes, I'm always managing the patient. If you can accept it, no problem. But nobody will agree. They will say, I'm not diabetic. And they will take it for the next 2 years.
Okay, it's very important to know that sometimes people can come down with DM complications even with pre-diabetes.
Yes.
So you need to assess their insulin resistance, lifestyle therapy, and in those at high risk for, especially with other risk factors, metformin is not a bad idea.
Yeah,
now, exercise is one of the things that have been shown very, very strongly to prevent or delay progression, and weight control to delay progression to diabetes. Okay, question, Glamepryde, can't we go beyond 2 milligrams? No, don't go beyond 2 milligrams. If you want to go beyond 2 milligrams, call for help. Why is insulin not started sooner? And why do people refuse insulin if it is helpful? There is a concept of early insulinization, and sometimes it's a very good idea. However, people refuse insulin because of cultural beliefs, superstitions, and so many other things, especially also the fear of needles. But you can see the pen he held, that is actually the insulin pen. Show the patient. Sometimes even have a needle inside and check yourself. I'm telling you, we do it ourselves. So that they can see that there's nothing involved. Okay, so once you teach them, people are only afraid of what they don't understand. They will tell you that their mother was using injection and the mother died.
And he died, yes.
And it's because the injection, not the injection. So if the person needs insulin, has qualified for insulin, please start insulin. If you don't know how to start, ask for help. Okay, but when they're on insulin, you need to educate them.
One question. A woman has
questions.
been complaining of foot pain for the past 1 month now. A pain like sharp pain. Please, what could it be? Is one for me?
No, don't worry. Okay, so please, your personal consultation questions after you can just meet us, Abi, or you can send the patient.
You know where to come.
It's
Number
not, this
5.
is not. We cannot consult on stage. Okay, why is smoking implicated in all 3 deadly combos? Hypertension, diabetes, cardiovascular disease. Very simple. Smoking does so many things. It affects metabolism. It also causes vasoconstriction in a lot of the vessels. So imagine that you have your pipe pouring water on your car. When you reduce the diameter of the pipe, what happens? It increases pressure, right?
Yes.
So that causes and also reduces blood flow to the organs. When you add cholesterol, that will have already reduced blood flow to that organs. When you add the higher blood pressure, the diabetes, you have further worsened it. And so death is faster. People are more likely to have more MIs. Okay. This one is very long. This is an essay. What's the role of HbA1c for evaluation and not diagnosis? So we use HbA1c to monitor. Our targets for blood pressure, our targets for diabetes management include hypertension, target 130/80, lipids. Remember our lipids?
Yes.
Remember our lipids, they should be, if they have nothing else, 70 is the target. Okay, LDL 70. And then for sugar we use the tripod, not one, not just fasting blood sugar. Fasting blood sugar, random blood sugar, 2-hour postprandial, and HbA1c. I want to get the HbA1c less than 7. HbA1c above 8 is associated and correlated with a lot of complications, stroke, and all the like. So that is why HbA1c. Please, sir, can you talk on normal saline to control hyperglycemia? The reason for normal saline in hyperglycemia, somebody say, yes, let's answer the question here. Let's answer. That's why we are here. The reason why is that sugar will have dehydrated the body very significantly. So when a person has very severe blood sugar, the first thing we do is to correct that severe dehydration. When we give enough fluids, it helps to dilute the sugar, number one, but helps to, that sugar was pulling out, it was having a lot of urination also. Loss of urination, pulling out. By the time the sugar enters the renal tubules, it draws water too, goes out of the system, right? So the person is very, very dry. So that excess fluid we are giving is to try and rehydrate. If you give a lot of fluid in that severe hyperglycemia, the first thing you know is that without even insulin or anything, the sugar will come down first. The person will start feeling better before you now and or with your medications. All right. I think that's about all that we have here. Any other burning question? Burning question. There was someone that was holding their hand. I'm sure we've answered it now. That'll be answered. Perfect. Great. Thank you so much.
Thank you so much. So now I'm sure you can run it, Abi. All right.
We're supposed to do something.